Hello and welcome back to GP Video Podcast by Nadia. So I'm going to make the last video on menorrhagia or heavy menstrual bleeding, and in this one I'll try and be quick and summarize definition, causes, investigations and treatment. So heavy menstrual bleeding has been defined as excessive or extensive menstrual blood loss which interferes with the woman's physical, emotional, social and material quality of life. 1 in every 5 Australian women suffer from heavy menstrual bleeding or menorrhagia, which actually can have a lot of consequences and is not at all nice for in any aspect, even when it's happening, and for its consequences as well. So as I said, heavy menstrual bleeding is also called menorrhagia. So basically, if we talk about it scientifically, then menstrual bleeding or menstrual cycle bleeding that a woman gets once in a month or in 28 days should not be more than 40 mLs or should not be more than 7 days. Excessive menstrual bleeding is defined as anything which is more than 80 mLs. But how are you going to quantify that, whether it's 40 ml, 80 ml or more? So there are a few signs and symptoms that we talk about. So the diagnosis is based on symptoms such as changing pads every 1 to 2 hours, bleeding lasting more than 7 days, and passing large clots. A diagnosis can be made based on a self-report of very heavy periods, and as I said, heavy menstrual periods can have a significant impact on quality of life. Now, again, I would repeat that an unusual increase in blood loss, more than 7 days of bleeding or flooding not contained within pads or tampons, clots greater than 3 centimeter, and the presence of signs of anemia, chronic lethargy, fatigue, or iron deficiency on blood testing. So now, what are the causes? Number 1 cause is dysfunctional uterine bleeding. Dysfunctional uterine bleeding is a diagnosis of exclusion, which we will come up to once we have done all the blood tests, scans and everything, and now we know that there is no other cause, so we will term it as dysfunctional uterine bleeding. The pathophysiology is not known. Dysfunctional uterine bleeding is the cause of 40 to 60% of menorrhagia, and usually it happens in women aged 30 to 50 years of age group, or it can happen at the extremes of both ages, like when a woman starts menstruating, which is menarche, for a few years, or in the perimenopause period, which we've already discussed, that the periods can be either light or very heavy. So the pathophysiology, as I said, is not fully understood and it is complex. It is a diagnosis of exclusion, and uterine and other causes must be excluded before the diagnosis is made. So what are the other causes? The other causes can be, as I have said it in other videos as well, that it can be after dysfunctional uterine bleeding, it can be categorized into 4 broad categories. Number 1, hormonal. Number 2, changes within the uterus and cervix. Number 3, blood disorders or medications causing blood disorders. And number 4, other systemic disorders. So hormonal could be anything in the body. So for example, polycystic ovarian syndrome. Polycystic ovarian syndrome itself is a big topic on which I would like to make some video podcasts as well. So in polycystic ovarian syndrome, again, women can have oligomenorrhea, which is very irregular and very scanty blood bleeding, or menorrhagia, which is heavy menstrual bleeding. Number 2, thyroid issues. Again, in thyroid issues, either you can have oligomenorrhea or menorrhagia. Then apart from that, again, so anything which is perimenopause, again in perimenopause, because estrogen and progesterone levels are up and down, so it can have either dysfunctional uterine bleeding or hormonal menorrhagia. Okay. Then we come to the most important causes that we really need to exclude, and these are called uterine causes. So number 1, fibroids, adenomyosis, uterine polyps, leiomyomas. Then precancerous or cancerous changes, uterine cancer and cervical cancer. So uterine causes are very, very important to be excluded. Then we have got bleeding disorders like von Willebrand disease or others, coagulation disorders, and any medications which can increase the risk of your bleeding. Apart from that, in systemic disorder, any liver or kidney disorders can also cause menorrhagia. Okay, now how will we investigate it? In investigation, we'll first do the blood test. Number one thing that we need to exclude is pregnancy. So we'll do the pregnancy test to see whether, though that's not a symptom of pregnancy, but sometimes when a patient is pregnant and then like it's in the phase of something not good is happening and the patient is in the phase of just, not retaining the pregnancy, they can heavily bleed. Then apart from that, so pregnancy test is number one. So we want to exclude that there is no pregnancy. Apart from that, we'll do full blood count to see whether the patient is, losing hemoglobin, is getting anemic. We'll do iron studies to look at ferritin, which is the stored iron, to see what's happening if the woman is getting iron depleted. Apart from that, we'll do kidney function test, EUC, and liver function test. Apart from that, we'll also do coagulation studies, bleeding and clotting disorders, to exclude all of that. So pregnancy test, full blood count, EUC, LFT, and coagulation profile is very, very important in doing the blood test. So that's number one. Number two, cervical screening test. Usually cervical screening test begins after 25 years of age, but if needed, we can do before that as well. So cervical screening test is very important to see whether the patient is having any risk factors to, or is developing cervical cancer or not. Then comes ultrasound scan. So ultrasound scan is a pelvic ultrasound scan, is an internal ultrasound scan in which we look at the uterus and the cervix and ovaries and all, to look whether if there is anything that we can obtain from there. And then if needed, if there is anything is abnormal in all of this. So for example, if there are any blood test abnormalities, any cervical screen abnormalities, or uterine abnormalities, or ultrasound scan abnormalities, then based on that, we can do the specialist referral. But if we are not doing the specialist referral and we are trying to manage this on our own, then what are the possibilities? So Mirena is the progesterone containing IUD, intrauterine device. That's number one choice to treat it. What it will do is it will regulate the menstrual cycles, and menorrhagia will be cured for sure, most probably, like in most cases. Then we have got, if woman does not want to have Mirena, then the options are divided into hormonal or non-hormonal. In hormonal, we can use combined oral contraceptive pills or progesterone only pills, depending on what women's contraindications and indications are. And non-hormonal therapy, which is short-term therapy, which is just done when patient is excessively bleeding. Number one is tranexamic acid, which is one of the antifibrinolytic agents, which stops the bleeding there and then, used for 3 to 5 days, or non-steroidal anti-inflammatory drugs, which are used again for stopping bleeding, and also if there is any pain associated with it, that also relieves that. So tranexamic acid or NSAIDs, they can be combined with the hormonal therapy as well, which is COC, combined oral contraceptive, both estrogen and progesterone, or progesterone only pills. So Mirena is number one. Then number two is hormonal and non-hormonal therapies. And if referral is indicated, then for example, if the patient is having fibroids, having leiomyoma, having polyps, then the referral is needed for the gynecologist to be able to identify that, and then do any ablations, endometrial ablations, or removal of polyps or fibroids as if needed. Thank you so much. See you tomorrow.